Is.
Good morning, everybody. Now you understand me better? All right. As you know, IBD can be related to colon cancer. However, there's still a debate how high the risk is increased. There are two studies I'd like to show to you. One is a national cohort study in Denmark, and they showed there was just a mild increase in the cancer risk, and in Crohn's disease, it was even decreased. That has led to a lot of debate, but then in the same journal issue, you see that the colon cancer incidence, at least in North California, was still increased. So I think it makes a lot of sense to look for colitis-associated cancer. At the moment, we do have three endoscopic possible modalities. One is the classic, which is colonoscopy with targeted and random biopsies. The next is maybe the new standard, which is colonoscopy in conjunction with chroma-endoscopy, and you only do targeted biopsies. And then maybe advanced and only in dedicated centers where it is available, you can combine chroma-endoscopy and endomicroscopy to target your biopsies only to suspicious areas. What will we have tomorrow? We might have new forms of virtual chroma-endoscopy. We might have full spectrum, full view colonoscopy, and we might have drug-induced chroma-endoscopy, and very much in the future, even functional and molecular imaging. But I'd like to start with the basics. As you know, some patients are not so well prepared, so we have to clean first the colon and then look for subtle changes. If you then use virtual chroma-endoscopy, you might see better the reddish area in the 6 o'clock position, and then you can apply some dye, indigo carmine or methylene blue, to fully delineate the lesion. There's a debate about the value of random biopsies, and there was a recent publication by the Netherlands group showing that there's a low yield of random biopsies. So even if you do not use chroma-endoscopy, look very carefully on even subtle changes and then try to target on those suspicious areas. And also the endoscopic techniques have evolved. If you look back in 2003, that was the time when chroma-endoscopy had such a big momentum because it was very difficult to delineate here lesion. You thought this is all chronic inflammation, and then if you apply dye, then all of a sudden you can unmask lesions which could be then better identified and maybe even endoscopic resection for diagnostic and sometimes therapeutic purposes where possible. These are the images of today where high-definition endoscopy is combined with chroma-endoscopy, and then you see the trend, the lesions are getting smaller. This is high-grade dysplasia on the left, and this is a depressed early cancer on the right. Another thing is that we have to learn to read the surface architecture, because to read the surface architecture helps us to predict the final histology, and there's the famous Kudo pit pattern classification, which can be also used in IBD. It might be a little bit more difficult due to the inflammation, but still it's a valuable tool. I'd like to show you a short video clip how chroma-endoscopy really can help you to identify lesions and also show you the problem of colitis-associated dysplasia. This is a quite young woman, 38 years of age, and if you looked in the rectum with white light, there was no lesions to be identified. The approach of chroma-endoscopy to do a somehow pan-chroma-endoscopy, so you stain segments in the colon and then you re-inspect that area. Here I use a dedicated endoscope, it's a zoom endoscope, and there you can see even the single glands within the colon, and this is normal architecture, so to say, Kudo pit pattern 1. However, even more striking and more important is to identify lesions, And here you see that the lesion is completely flat. It's a so-called type 2B lesion. It's inside the mucosa, and with chromendoscopy you can delineate the border, and then it's easy to target your biopsy or to guide your endoscopic intervention. And with all the studies now in chromendoscopy, all studies were positive. And there's a number needed to treat of 14, meaning you have to do chromendoscopy in 14 patients using methylene blue or indigo carmine, and you will find one more patient having intraepithelial neoplasia. So the consensus of ECHO, which was in former times that chromendoscopy is an alternative, has now changed to that chromendoscopy is now recommended for surveillance as a better alternative compared to random biopsies. But maybe in the future we do have pills and drugs, and there's a recent study where people ingest pills with the MMX technology, and then methylene blue is the pill is open, and then methylene blue is distributed over the colon prior to the colonoscopy during colon preparation. And Alessandro Repici has led the first study showing that with this kind of technique, the adenoma detection rate was much higher. There are new endoscopes, and you might see them also in the exhibition. That's the new fused colonoscope, where you have 3 optics at the distal part of an otherwise standard conventional endoscope. I hope you can see the video. The resolution is not perfect, but maybe you get a hint how this works out. So you see light on the left and to the right. This is now somehow live endoscopy. It was one of our first cases. And then you see you have 3 monitors which covers 300 degrees of the colonic tissue. But I think what is even more interesting at the beginning during intubation with the endoscope, that you can navigate much easier because you always see to the right or to the left. Now look to the center image. Now here we move towards the left flexure. Now it's quite easy, but then all of a sudden you will see you do not know whether you can go to the left or to the right. And then it's like car driving. Now you look whether it's on the right or the left, the opening, and it just turned to the right. You see, then you switch a little bit too much to the left, and then you can very nice center the image. You see the appendix orifice and simultaneously the opening of the Bauhinge valve, the ileocecal valve. So that is interesting, and it might be that you see even more polyps also in IBD patients. It was shown in standard colonoscopy that this is the fact if you use the fused colonoscope that you can identify more polyps, as it was shown in back-to-back colonoscopy in 185 patients presented at the first time, DDW 2013, which is now published in Lancet Oncology. An alternative is the so-called GI balloon. You have a balloon at the distal end of the endoscope, and that balloon is once insufflated during withdrawal of colonoscopy, and that balloon adapts the size of the colon, and that is straighten the folds in the colon and also kind of catches the air in front of the balloon as well as it centers the image. Then you have the impression that the colon is a little bit over-insufflated, however, even less air is needed as normally, and then you can see especially well between the folds, and then it's even easier possible to identify polyps in between folds, and that might also be a technology which can easily be used in our IBD patients. And the first study where we were also participating showed that the miss rate after initial GI colonoscopy is minimal, but if you do a second colonoscopy with that, with standard colonoscopy, or with a balloon after standard colonoscopy, you see you can double your findings over 100%. The filter techniques I would like to go over because, as you know, NBI, iScan, FICE, or SPICE are available, but all trials have shown that NBI is not of help in ulcerative colitis because we see so well the vessels, but the vessels are already changed and altered due to the chronic inflammation, and 2 studies have shown that there is no benefit. At the end, I'd like to show you that how important it is to do chromendoscopy, because here you see a colon cancer. You can't see. There's a cancer. So let's switch on virtual chromandoscopy to identify cancer. Still a little bit difficult, might be a reddish area based on a biopsy, but then you just use a little bit of methylene blue, and then it's a rare cancer for sure, but these are the early depressed cancers which only can be seen so nicely after chromandoscopy, and you see the beauty and the power of chromandoscopy. Endomicroscopy is something very special where you can do microscopy of the tissue, and specialized centers can be used to further define the area where you would like to do the biopsies, but I think it might still take time before this is available in more broader clinical practice. So today we have a lot of possibilities. Look careful with your best endoscope you have. Please use more chromandoscopy, especially in IBD patients. And maybe tomorrow it's much more easier because we have wider view, better view, and we might have even drug-induced chromandoscopy where the patient takes a pill during bowel preparation and then the colon is already stained. Thank you very much for your kind attention.